previously discussed how adenosine was helpful in the dilation of the coronary arteries. Remember back to the autoregulation part of the physiology section. Adenosine is produced when there is accumulation of precursors such as ADP and AMP. These are precursors of ATP. So when there's insufficient amount of oxygen, because you need oxygen as the final electron receptor, when ATPase is working to make ATP, therefore in an anaerobic or oxygen-deprived state, these factors accumulate. They will eventually be broken down because the cell does not just want to use up its resources to make something. The cell will break them down into adenosine. Now, why is that important to us? Well, it makes the body seem like it's really smart. Let's visualize what is actually happening with these mechanisms of action of adenosine. So, it is important to know there is an adenosine 1 receptor and adenosine 2 receptor. So let me just draw for you the associated effects. So the adenosine 1 receptor is associated with the inhibitory component of the G protein complex. The GI or A1 receptor, this is in the SA and the AV node, while the A2 receptor is very prominent in vascular smooth muscle cells. So when adenosine binds to A1 receptors in the SA and AV node, it activates the inhibitory GI protein, which we know inhibits adenylyl cyclase, which means we will be producing less cyclic AMP, and without any cyclic AMP, there will be less activity of protein kinase A. And we know that protein kinase A is needed to help open some L-type calcium channels, and it is needed to phosphorylate phospholamban. But since we're not doing that, we get increased activity of phospholamban, which means that it inhibits the sarcoendoplasmic reticulum calcium pump that is pumping calcium into our SR for storage and increased release of calcium for future events. So basically the net overall effect is that we have a decrease in calcium, which means that we know we have less contractility and a decrease in heart rate. Because cyclic AMP is also important for the activation of the hyperpolarization activated cyclic nucleotide channels that set our intrinsic funny current that gets us to the depolarization threshold more quickly when there's more cyclic AMP around. You also get the net overall effect of lusitropy, and this kind of tells you what it is. Lusitropy, it kind of sounds like loose, and this makes a lot of sense because we have increased the relaxation of the myocardium because there's less intracellular calcium within the myocytes. This should all make sense considering phospholamban is not inhibited when you administer adenosine, and it will prevent circa from storing calcium so that our subsequent contractions are not as forceful or fast. We need to also quickly discuss adenosine's effect on the HCM channel. Let's just visualize that. Remember, hyperpolarization activated cyclic nucleotide channel. They are intramembranous structures that open when cyclic AMP binds to locations on the intracellular side of the channel. So again, less cyclic AMP, less opening of these channels that set our intrinsic depolarization rate. So what else does adenosine do for us? Remember that you have a different type of adenosine receptor on vascular smooth muscle cells, the A2 receptor. You must understand that while A1 is associated with the inhibitory GI protein, A2 is associated with the stimulatory component of the G protein complex, which means that will actually lead to an increase in cyclic AMP. And we know that this will activate our protein kinase A, and it will end up phosphorylating and inhibiting myosin light chain kinase, and we get a relaxation of our vascular smooth muscle cells because myosin light chain kinase is needed to phosphorylate the myosin light chain. Let's visualize this because we keep on saying it over and over again. Protein kinase A is actually a structure that is composed of 4 units, and these are the regulatory subunits that are binding these active units and inhibiting them from doing anything. Cyclic AMP binds these sites of the regulatory subunit that is attached to the inactive catalytic or active subunit on the right. So these are the active catalytic subunits. Cyclic AMP binds the regulatory subunits and causes a conformational change so that these now come off and they break their attachment to the catalytic subunits. This allows the kinase to now be active. So they are now active while these subunits are separated. An active protein kinase A will now be able to phosphorylate things. We keep saying that it will phosphorylate the myosin light chain kinase. So when you phosphorylate myosin light chain kinase, you prevent it from performing any phosphorylating activity. So myosin light chain kinase is inhibited when it has a phosphate on there, thanks to the work of protein kinase A. So if you remember, the myosin molecule is very long, and there are two heads. There is a light chain that is associated with the myosin head here, and a light chain associated with light chain on this side. The myosin heads are the ones that interact with the myosin binding sites on actin. The myosin head pulls towards the midline of the sarcomere, and they need to return to their original position. So they go this way, and then they need to be cocked back. They require a phosphate group attached to these light chain sites here and here to do so, because they need energy to return to that state. If myosin light chain kinase is inhibited, there is no phosphorylation of these sites, and there is no return of the myosin heads to the cocked position. Therefore, you get vascular smooth muscle cell relaxation. So let's discuss how this applies to the diagram on the slide. Do you see here how there is a block due to this atherosclerotic plaque right after the bifurcation of this coronary artery? If we give adenosine, we can increase the diameter and caliber of the vessels, because we just said that it causes vascular smooth muscle cell relaxation. Seems like an excellent idea, so we can squeeze more blood past these bifurcations. So this is the pre-adenosine diagram, and this is post-adenosine. So it seems like an excellent idea to give adenosine so that we can get more blood past these atherosclerotic impedances to flow, right? Wrong. This is the phenomenon of coronary steal syndrome, which is a particular favorite because it tests your understanding of coronary artery physiology and adenosine pharmacology. So you give someone adenosine, and they go from this state to this state. We actually cause shunting of blood away from the atherosclerotic branch. Do you see how there are more flow arrows now that we have given adenosine? This represents the increased flow in the other arterial branch that has no stenosis. It is fully capable of vasodilating and taking on more blood flow. This is not the ideal situation, considering we are now going to shunt blood away from the stenotic branch, because whenever you have atherosclerotic plaques, there will be some intrinsic damage to endothelial and vascular smooth muscle cells that initially presents with endothelial cell dysfunction. So a lot of time, these can't even respond to the adenosine anyways. So the combination of the lack of response of adenosine in these stenotic branches, plus the fact that there is a increased diameter on this side, which will increase flow, means that we are actually going to be shunting blood away from the branch that actually needs it the most. This can actually further exacerbate the oxygen deprivation of the myocardium that is supplied by the branch that is stenotic. This is the basis of stress testing and can potentially cause angina if you give someone adenosine. And that is the chest pain that is potentially associated with administering adenosine. This is due to the fact that we are changing the hemodynamics of these coronary vessels. And in an atherosclerotic patient, it is a terrible situation, because that myocardium is starving for oxygen, and then now we're going to shunt more blood away. Terrible idea to deprive an area of more blood that's already struggling to adequately perfuse areas after the stenotic lesion. So one last point regarding the mechanism of adenosine. It is also capable of causing increased potassium flow out of cells. So that means that these cells are now losing more positive, and they get further away from the threshold transmembrane potential. This is good because we want those cells to be hyperpolarized and responding less. The potassium channels that are targeted by adenosine are only present in the atrial myocytes. Well, that's kind of a unique situation, isn't it? That is why adenosine is so helpful for abnormal stuff going on above the AV node, also known as supraventricular things, such as tachycardia, because it will block intracellular calcium increases in the AV and SA node, has a very short half-life, and also directly affects atrial myocytes' potassium conductance by increasing it, hyperpolarizing those cells. You only need a transient block to kind of reset the AV node back to normal. So adenosine is particularly useful and short-acting. The adverse side effects of hypotension and flushing are directly related to the mechanism that it stimulates vascular smooth muscle cell relaxation because it causes an increase in cyclic AMP and inhibits myosin light chain kinase from phosphorylating those myosin heads, and they can't return to their COX state to contract again. So by preventing the vasoconstriction, we decrease the total peripheral resistance. Remember, blood pressure equals cardiac output times total peripheral resistance. And that means that we can get hypotension because we're dropping our blood pressure. It also inhibits the opening of the hyperpolarization cyclic nucleotide gated ion channels that sets our intrinsic depolarization rate. Remember, cardiac output is heart rate times stroke volume. So if we decrease the heart rate, we're decreasing our cardiac output, which further decreases our blood pressure, which means that we have two ways that we can get hypotensive here. The other side effects are related to the inhibition of vasoconstriction as well. So vessels will dilate and get much closer to the skin and create flushing. You can see this mainly occur in the facial artery distribution, so they look nice and rosy red-like. Patients do not like looking like cherries, so you have to be careful here. Patients also don't like having chest pain. It scares them. This is one of the particularly high yield side effects because anything that makes patients feel like they're dying will bring them to the doctor. The chest pain side effect can be related to the coronary steal phenomenon we just discussed. Remember, there are A2 receptors present on vascular smooth muscle cells, and this A2 is associated with GS. Where are vascular smooth muscle cells located? Well, in the respiratory tree, such as bronchioles. If you inhibit the ability of these bronchioles to regulate themselves because you are causing an increase in cyclic AMP, and therefore these cells will be relaxing, there can be a point where you can actually cause a vascular smooth muscle spasm. So you can have bronchial spasm, which kind of presents like a chest pain. This can make patients feel like they're having a heart attack. So how can we block the effects of adenosine if your patient is having these side effects of flushing, hypotension, and chest pain? We use two drugs that have a very similar structure to adenosine. So the adenosine molecule is a very important structure because we have very similar presentation that you must know from your biochemistry section. What does this molecule look like to you? Well, it's just a purine nucleoside with a ribose on it. So this is the purine component, and then this is the ribose component. Remember, the difference between a nucleoside and a nucleotide is that a nucleotide has a phosphate group on it because you used an ATP to make it. So why am I drawing this out for you, considering you don't even have to remember the structure? Well, it helps to visualize how there's a similarity between the adenosine molecule and how theophylline and caffeine can antagonize the adenosine receptors. Let's compare by drawing out theophylline and caffeine. So both theophylline and caffeine are very similar to each other and look really similar to the adenine that is within the adenosine molecule. The only difference between theophylline and caffeine is at this structure here. Theophylline has a hydrogen while caffeine has a methyl group attached. That is why they are called methylxanthines, which means they're basically a purine, which is a xanthine component. Look at the similarity between this structure and this structure. They both have nitrogens in these locations, and that is how caffeine and theophylline are similar in molecular structure. And that makes it the foundation for the reason behind using these drugs to reverse some of the effects of adenosine. Remember, adenine is a purine base, and xanthine is a purine base as well. Who knew we would have a little biochemistry review sneak into our lecture here? So the similarity of these groups between the adenosine and caffeine and theophylline makes a lot of sense because adenosine stimulates these receptors while caffeine and theophylline inhibits them. Basically, these similarities allow caffeine and theophylline to just sit in the adenosine receptors without actually causing the induction of intracellular signaling. So they block the receptor without actually having the end result. So we already said that both caffeine and theophylline are non-selective adenosine receptor antagonists. But in addition to that, theophylline is actually a phosphodiesterase inhibitor, which means that it will inhibit the enzyme phosphodiesterase that is responsible for the breakdown of cyclic AMP. Without the breakdown of cyclic AMP, we get an accumulation of cyclic AMP. This helps reverse some of the side effects associated with adenosine, particularly the bronchospasm, because now we can allow the bronchioles to relax a little bit more. Remember, we illustrated that the stimulation of receptors in the bronchial tree can cause bronchospasm because we are changing the normal intracellular levels of cyclic AMP. Giving the patient some theophylline will not only antagonize the adenosine receptors in the bronchial tree, but you can also prevent the breakdown of any cyclic AMP that might be in that intracellular environment. The end results will be counteracting the effects of adenosine.